Now, whenever I get that countdown, I want to say lift off. So instead, I'll say a big welcome to everybody to this week's Maternity Midwifery Hour. My name's Sue Macdonald, and I'm the curator for Maternity and Midwifery Festivals and Maternity Midwifery Hour. It's my pleasure to be chairing this session this evening. This is now Series 13, Session 8. I have to keep remembering how far we've come since 2020. And I'm delighted I've got two lovely speakers this evening. I've got Jemima Skilling and Sarah Milnes. And we're going to put them on the spot like we always do and ask them to share a moment of the week. And we'll start with Jemima. Do you have a moment of the week to share with our lovely audience?
Yes, I am moving into my first non-student house very soon, and I have started furniture shopping this week, which has been very fun.
Yeah. I want to know what's going to be your first piece of furniture.
The first piece of furniture we got was a very nice vintagey cabinet for our hallway from a charity furniture shop, so it's even more satisfying because it's sort of one-off. So
lovely.
it was very, yes.
And this is true reusing and recycling and having something of beauty. Oh, wonderful. Thank you, Jemima. That's lovely. Now, how about Sarah? Let's put Sarah on the spot here. Your moment of the week.
I was super proud of my 10-year-old son because he had to go to the dentist today to have a tooth out, had to have an injection, and he was super brave, didn't flinch, really good as gold. Really proud of him.
Wow. And that's what I admire, because even I would flinch at the idea of an injection and the being at the dentist, full stop, really. It's a real challenge. So well done him. Thank you for that. That's lovely. So two lovely things to share with us. Now we're going to allow Jemima and Sarah just have a moment or two while I just highlight, for those of you who are new to Maternity and Midwifery Hour, where we all came from. And I don't mean right at the beginning where we came from, but you know, why the Maternity and Midwifery Hour started. Then we'll do the little news feature, and then we can go on to the main bread and butter of this evening's session. Now, you'll probably, some of you will think, well, this hour's always been here, but actually we started right at the beginning of the pandemic lockdown in 2020, March 2020. And we started really to make sure that midwives, because you might remember that time, lockdown, no study days, no conferences, no festivals, very limited face-to-face contact, except in the workplace with all the masks and the PPE. And we really wanted to make sure that midwives and student midwives had connections, had some access to information, knowledge, especially around at that time, COVID-19, what was going on in the services, what innovations were going on in the maternity services, and there were an awful lot at that time. As always, midwives are pretty good like this. And also about what COVID was and how it was all emerging and all that sort of thing. We've obviously still going 4 years later, not so much obviously with COVID. We've kind of moved on to normal midwifery, normal maternity services, whatever normal is, because it seems there's always something going on and it's very busy, it's very stressful. And I know midwives are probably quite tired because we know there's a shortage of midwives. We need more, and hopefully in the next few months, years, we're going to get more because we're training plenty. Important to keep our midwives as well, because we've got a huge amount of knowledge and skills within the workforce we want to keep on to. And I just want to say a big thank you to midwives who are working so hard to do what they do for mothers and babies and families, and student midwives, and all the whole team of maternity care professionals, because there's a whole gamut of people who keep the services going. So good on you, and keep on doing what you're doing, but also keep on looking after yourselves and look, you know, so you are able to do what you do so well. Now I'm slipping almost indubitably or whatever, can't think of the right word today, into the news feature. Now today is, and I think this is very appropriate, where there has been quite a bit of discussion about environment and reducing carbon footprints over the next few days, especially in the political world. And today is the UN World Environment Day, which is great. We need to always think about ways in which we can reduce our carbon footprints and waste, not recycle, reuse where we can, and just not waste so much stuff. And I think I was noticing is all the veterans today going, and especially into France and commemorating D-Day. And you think in that time, you had to make do amend because you couldn't just go out and buy a new thing. You had to renew, mend, fix the thing. So it kept going. And I think we could learn a bit from those days, really. I'm not saying go all the way back, but we could certainly reuse and recycle. Anyway, also, tomorrow is International Home Birth Day. And for midwives, that's very important. So a big hurrah to those of you who are looking after women and babies within the home and doing home births, because that's an area where we're kind of not as big numbers as we'd like to be, I don't think. And it's such a privilege when you can go into a woman's home and help her give birth to her baby with her family around her. It's something very special. So hurrah for the women and hurrah for the midwives providing that care. Now, the other thing is this month it's Pride Month. So there's been a lot of rainbows around, and there's also a lot of activities going on and marches and things. But of course, the news is a bit overshadowed by all the political stuff going on for the elections. But I'm not going into that because I think that I've certainly heard that on the radio all day, and I think everyone's probably got quite enough not to come on to maternity midwifery hour. So just one of the things that I really noticed, and those of you who watch often will know I'm a real tweeter, and one of the lovely tweets I noticed was a fantastic image of 1,475 silhouettes of men and women from the UK who fell on the 6th of June. And this is called Standing with Giants exhibition. It's in the British Normandy Memorial till the end of August. And it's very powerful because you have these beautiful fields with a few daisies. I didn't see any poppies, mainly daisies and green grass. And then these figures just silhouetted on the sky. Very powerful, very moving. And it makes you kind of realize how many is 1,475. So a lot of people lost. So something for us to think on. There's also, I just want to highlight the WOW, that's the Wellbeing of Women / Royal College of Midwives level, entry-level scholarships. Still going, it's still open for submissions. Submission is on the 11th of July, and this is a way of getting potentially a grant to undertake research into maternity care or midwifery. So have a look on the resources sheet and the information that is there to go. Now, I'm almost at perfect timing, but I'm actually a little bit early because I'm speaking very quickly because I'm really keen to get on to the meat of this session. Now, we're going to be looking at empathy. Now, I think one of the things about empathy is we kind of think we all know how to do it. We all know, of course, I'm empathetic. But sometimes with these taken for granted things, a bit like reflection, a bit like compassion, it's quite good to have a little think about what it really means in day-to-day practice. And I'm really so delighted to be joined by two people who are going to help us just think again, just challenge our thinking a bit maybe, and talk about some of the things they're doing to help, especially students, but also midwives, I think, really develop their empathetic skills. So first of all, I'm very delighted to introduce Sarah Milnes. And Sarah's been spoken here before. She's a midwife, a hugely experienced midwife, and she's cared for women across the childbirth continuum, including and especially women with additional care needs. She's got a huge passion for teaching and supporting students and really improving practice. And she kind of got led into academia and became a teacher, lecturer, and she's completed an MSc in midwifery, and she's presented and published a dissertation examining experience of student midwives who enter the profession as mothers. It's really interesting work. And she's at the University of Leicester, and she's with us this evening. So welcome, Sarah. Thank you so much for coming this evening, and the screen is now yours to share your empathy work. All being well. if the technical, if we don't have any gremlins.
Maybe. Right, there we go. First gremlin. Okay, good evening, everybody. Like Sue said, my name's Sarah Milnes, and I'm a lecturer at the University of Leicester, and I'm really passionate about mental health and birth trauma. And the last few years, I've been looking into empathy. So I'm just going to take you through some of the things that I've thought about and considered along the way. So what is empathy? So empathy is putting yourself in somebody's shoes, walking a day in their life, understanding their thoughts, feelings, perceptions about the world. And that's different for everybody, and it's different for different people. Sometimes it's really easy in maternity to compartmentalize people and treat people due to their illness or certain characteristics about them, so medical characteristics. But we need to kind of step away from that and see the world through their eyes, and actually how can we improve care for them as an individual. So there's this thing called parity of esteem. It's something you might be familiar with, it's something that you might not be familiar with, and this is valuing physical and mental health equally. So what a lot of the research suggests, that if you take nursing, for example, if you are a physically trained nurse or if you're a mental health trained nurse, you can't recognise complications across the disciplines. So actually, people who are under the care of somebody who is a single reg qualified are more likely to die, they're more likely to have complications, more likely to have problems. So one of the things that we're trying to do at the minute is to ensure that people have an appreciation of mental health and physical health, and that's something that we teach at the university. So we have a dedicated perinatal mental health module, and we run it through all of our modules. So we're not just looking at the physical aspects of pregnancy and maternity, but we're thinking about that holistic care. So we're having this holistic approach where we're looking at the social side, the spiritual side, the physical side, the psychological aspects of that individual person. And we're trying to treat the person and not the illness. So like I said, pregnancy impacts individuals very differently. And so it's about listening to them, talking to them, finding out how we can help them as an individual and understand, why, how and what they're experiencing. So I'm just going to take you through a pregnancy journey. Now, as a midwife, it's quite easy to get very task orientated and task focused. And sometimes it's good to step back and look at the care we're giving through the eyes of somebody else. Because we are au fait with this. It's our bread and butter, it's our everyday. We understand all of these things. But actually, the people that come into the service and the people that we care for, this might be the first time they've had sustained contact with the National Health Service. They may have never been to a hospital before. So even just like sights, smells, noises, they're very familiar to us. They're not scary to us, but they can be scary to people that are coming into the system. So I just thought we'll take a walk through, and it's always good, like Sue said, to reflect and to remind yourself of those things that these people might be experiencing. So the first trimester, lots of people are happy that they're pregnant, they're really excited, full of happiness, joyful, something that might have planned. But some people, that might not have been the right time in their life to find out that they were having a baby. So some people actually come into the services feeling very scared. They're worrying. They have a lot of anticipation because they might not feel ready to be parents. So sometimes greeting people with congratulations is not always the thing that everybody wants to hear. So again, it's looking at those cues to find out how families feel about this situation. How they feel might be dependent on whether the pregnancy was planned. They might be thinking, well, now my life's going to be really restricted because of certain things that I can and can't do. I'm now going to have a child to look after for the rest of my life. So they feel like they've lost that independence, because I tell you, before I had children, I could pop to the shop. And then as soon as I had children, I would probably have to feed them, change them, feed them again, maybe change them again. Then they'd be sick. And you've got to tackle the car seat, get in the car, and then 45 minutes later, you might be at the shop. So nothing is straightforward once you've had children. children are expensive. You know, it's costs a lot of money to raise a baby, and not everybody's in that situation, particularly the cost of living nowadays. And also, you know, with two parent working families nowadays, two people have to work to keep a house afloat. So for someone suddenly say, oh, I'm going to have to go on maternity leave, I'm going to have to take a pay cut, or I'm going to have to, you know, maybe go part-time or afford childcare. These are all things that scare people. And so they're already feeling this anticipation. They might not have any family support, because what happens, people go off to university and then they meet somebody at university and then they stay there, and then their parents are 200 miles away, and we don't have these villages anymore where we know everybody and we help each other out. And they might be thinking, I've got nobody around me to help and support me through pregnancy, or support me when I have a newborn or a toddler. There might be cultural pressures or expectations of things that they should do in their pregnancy that they might not necessarily agree with, but feel this cultural obligation to do it for their family. So again, that's another consideration. And I think this is one, certainly when I was a midwife and I was a student and, you know, worked on community, I think women that are experiencing pregnancy following a loss, I don't think we put enough emphasis on it, particularly at the booking appointment, because we just say, oh, what number of pregnancies are this? And they'll say, oh, I've had a miscarriage. I had a miscarriage at 5 weeks, 6 weeks. And we just write it down. And I think we need to maybe just have a think about how that's going to make that person feel coming into pregnancy after following a loss of a baby. So again, in the first trimester, women might fear miscarriage, and this can give them huge anxiety, particularly, like I said, if they've lost a baby before. A lot of women get an implantation bleed around 5 or 6 weeks, end up having to go for a scan. And again, you know, they say that sometimes it's just a conveyor belt. They just go through and they get a scan to reassure them. But actually think about how that person's feeling. They're bleeding. Bleeding is the first sign of miscarriage. They're going to think the worst, aren't they? So again, it's just thinking about how those people are going to feel. And families often delay announcing a pregnancy until after the 12-week scan, because in people's eyes, 12 weeks is like the magic time where they've had the scan and the baby becomes real because they can see it, because before they've not really felt anything, not felt any movement. So prior to that, they often keep it a secret from friends, families, colleagues, and then they might be struggling with things like morning sickness or extreme tiredness. And that can be really, really tricky if you're trying to hide that from people. And then they go to the booking appointment. So the booking appointment's really exciting because they're going to meet the midwife for the first time, and they're going to get themselves into the system, and it finally starts to become real that they're actually pregnant. And most women will book around 8 weeks of pregnancy, so quite early on, but also quite far along from when they conceive this baby. And straight away we say, okay, you can't eat this, you can't have that, you can't drink that. You should have had folic acid for 2 to 3 months prior to conception, but they may not have been on that. They may not have known. We should say, you know, we always say alcohol and smoking should be avoided when trying to conceive a baby because there's a risk of miscarriage. You should have a really good diet prior to conceiving your baby because of the impact that can have on the pregnancy. But so many pregnancies are unplanned. So if we start giving out this advice, it can give people a lot of guilt and anxiety. And we know that feelings of anxiety in pregnancy is not good for the pregnancy and not good for the baby. And I can tell you now, most people I've booked have probably conceived their baby in a sea of alcohol. So there is a lot of women out there that straight away feel very, very anxious. And it's about understanding and empathizing with that anxiety and try to put it into kind of probably going to be okay. But this is the advice that we have to give. The next thing we do is we offer people screening tests. Now, again, we're quite au fait with screening tests as midwives. You know, we know quite a lot about them. We practice evidence-based practice, so we're constantly reading research about screening tests. But for many women and families, if this is their first pregnancy, they don't really know anything about pregnancy or childbirth, because gone are the days where you'd probably support your sister having a home birth, or you'd witness birth in the community. Now birth is this thing that's shut away in a hospital, and unless you've experienced it, you don't really know much about it. And these women have a 1-hour appointment where they're bombarded with so much information that they're extremely overwhelmed. And then we ask them really, really important questions about screening tests. And when these screening tests come back, the results of which may lead to further testing, which can cause miscarriage. And also what we're testing for is chromosomal anomalies in the baby. So again, this is a massive decision to make with very little time to think about it and really very little information. And we know that studies say that women who are given too much information at once, they can't make an informed choice. They kind of just get swept along and go with what they think is right or what you think is right, which is even worse. So it's about ensuring that women have the right information and they have the right amount of time to think about it. I mean, if we were doing a research study, they'd haul us over the coals with ethics if we didn't give people long enough to think about and make an informed decision. So again, we need to be thinking about this with the women that we're caring for. And then women that have language barriers or learning needs, they're going to need even more support to make an informed choice and an informed decision, because it's going to be harder for them to understand. So then it comes to the second trimester, and women and families get really excited about the 20-week scan. And we even see it referred to on social media, don't we, as it's the gender scan, it's a sex scan. I'm going to find out if we're having a male or a female infant. And they fail to recognise, and I think, you know, sometimes we perhaps don't emphasise enough that scan is actually to look for anomalies. And if you find an anomaly at 20 weeks, that's a huge decision to make about where you're going to go with that information, because there's fear of the unknown. Often we see anomalies, but we don't actually know how that's going to pan out in that child or that family's life. And sometimes parents are left with a really difficult decision of whether or not to terminate a pregnancy. And again, that is a really, really difficult decision to make and a difficult thing to do. And I don't know if we put enough emphasis and support on those women making those decisions. So the third trimester, I've got a brick wall here, because you often find that women will think about the pregnancy and they'll think about getting up to labour, and that's it. They don't think about anything more. They kind of hit a brick wall and they can't get themselves past it. And so towards the end of pregnancy, people start to feel uncomfortable. They might be suffering with SPD, so symphysis pubis dysfunction, which is quite debilitating, really. And I don't think, again, we put enough emphasis on these. Things like symphysis pubis dysfunction and morning sickness and tiredness, they're referred to as minor disorders of pregnancy, when actually they can be really, really debilitating to women. They might have to spend time in hospital, away from their families, away from their children. You know, that's a very lonely place to be if you're suffering with these disorders. They might be really frustrated that the rings don't fit. I remember I got really annoyed that I couldn't tie my own shoelaces. That really, really annoyed me towards the end of pregnancy. They start to become really anxious about labour and birth because, again, you know, there's a massive lack of antenatal education nowadays. It used to be that community midwives would provide antenatal classes for all of their women. They'd all have 5 or 6 sessions, and they'd almost feeling like they had a little bit of knowledge about what was going to happen to them, regardless of what path they ended up taking. And I think now there is lack of information. And like I said, a lot of women have never been into hospital. They don't know what to experience. It is quite a scary place, first time you ever step in there. And everything you see on TV is scary. So, you know, women will labour really fast on TV. They'll go from 0 to 60. And that's how women think they're going to labour. And actually, they'll come in and they'll have a multictos, or they'll be 2 centimetres. And then, you know, what do we kind of say to them? We say, oh, you're only 2 centimetres. I mean, how awful is that to hear? I've had all this pain. I'm really struggling and I'm only 2 centimetres. And I always say to my children, never say just or only. There is always a positive. So even if you just go in and say, you know what, actually, you've done a lot to get to this stage. You're doing really well, you're coping really well, but at this moment in time, we don't know if it's going to continue or if it's going to settle down. So we just need to look after you for a bit and just make sure you feel better and put them in a nice environment where they're going to want to labour. Again, it's just putting yourself in their shoes. They fear the pain because, let's face it, nobody's experienced that pain before. They don't know how they're going to cope with it or deal with it. And they fear that lack of control. And actually, you see it, don't you? Women come into hospital and the first thing they do is they sit on the bed in the centre of the room and they just kind of say, oh, you do what you think's best. They lose that control. And I think once you lose that control of anything, of any aspect of your life, the world becomes a very scary place. And I think that can be quite scary for women. And towards the end of pregnancy, women always get a nesting instinct, don't they? I think I was painting the ceiling at 36 weeks pregnant and I was told off by my husband. But this is to try and regain a little bit of a sense of control because it's something that they want to do and something that they feel the need to do. At this stage, both parents start to think, are we going to be any good at it? Actually, I'm thinking back to my childhood. What did I learn? You know, what was my upbringing like? Can I do it? It's such a massive responsibility. And that's quite overwhelming for people to have that suddenly hit them. So unfortunately, what we're seeing is a lot of women are experiencing what we call birth trauma. The statistics are 1 in 4. I think maybe since COVID, it might even be 1 in 3 women now experience birth trauma. And it's not always a dramatic event. So we used to consider birth trauma as, oh, they've had a horrendous instrumental birth, a huge postpartum hemorrhage. That's a really physically traumatic thing. But actually, a lot of women and partners, dads, experience trauma because they felt that they had lack of control. They felt that they weren't listened to. They didn't have enough information. And the care that they received wasn't compassionate. And actually, multigravida women, so women that have had babies before, are 5 times more likely to fear birth in a subsequent pregnancy. And it's not just about subsequent pregnancies that we need to be concerned about. Actually, some of these women, it puts them off things like smear tests. It puts them off going to postnatal classes. They then end up with anxiety and depression, which has a huge impact on their attachment with their child. And we know the first 1001 days from conception to about 2 years old are the most important in a baby's life, particularly when, you know, the brain is developing. That's the biggest growth of brain development. And if you don't have a great attachment with your child, that can be hugely impacted. And then families look back and they feel guilty about that. So it's about supporting them all the way through. So families want choice. Choice is a big thing. I mean, it's fine saying that women have got this choice, but they only know what they know. And it's actually a really difficult thing to navigate the maternity services. I educate students about maternity services. I know everything across the childbirth continuum, but I can't tell you everything that's out there. And I think sometimes they have a faith in the system. So they almost go with what we think. And also when women are in pain, they're very susceptible to persuasive communication. So what might seem really kind as saying, oh, would you like an epidural? Or would you like pain relief? If they were adamant that they did not want that, and then you're doing the really kind thing, but actually you're saying almost this is what we recommend without saying it. Sometimes women will say yes, and then actually they turn around later and go, that's not what I wanted. But I went with it because I thought that was what was best. So they want control. And again, it's about giving them that locus of control. So just supporting them, find out who they are, what they want, what their desires are. And the other thing they want is compassionate care. Now, I know that everybody is really, really burnt out, and I go in and I see my ex-colleagues and I see how burnt out people are in the NHS, and it's really sad. But compassion actually, and empathy, it doesn't have to be a huge time-consuming thing. It could just be what we call a fleet of compassion. So it could be actually sitting down next to somebody, giving them eye contact, active listening, if you're asking questions as part of the booking appointment, I know everything's online now and people have to fill out things and you've not got a lot of time, but just look at them and just show them that you're listening. Put your hand on their arm, just really little things that can really make somebody's day, and let them know that you're listening to what they're saying. And that can be really, really important to people. So this is my little boy. This is George. He's now 10, so he's no longer this small. He's just as cheeky, but he's no longer this small. So I think it really hit me about empathy when I had George. He was 3 months old. And on Christmas Day in 2013, I thought I was getting a day off from the hospital, but I ended up going in because he was admitted to Leicester Royal Infirmary with bronchiolitis and dehydration. And it was horrible. They took him in and they put this NG tube down him. And I've put NG tubes in babies. I've fed babies through NG tubes. We send babies down for antibiotics. We do lots of things and very aware of the care that we can give to newborn babies. But when they held him down and they put that NG tube in, I cried and I suddenly felt very sick and it was horrible. And it suddenly made me realise that all the care that we provide, it's our everyday, but it's not theirs. And actually, this is one of the most important times in their life, and this baby is the most precious thing to them. And so we have to be thinking about how they are thinking and how they are feeling. And that's why I always say to the students when they go to the neonatal unit, go to the neonatal unit, spend some time there, see what it's like, then you'll know a little bit about what these parents are experiencing. And I think that's a really important lesson to learn, particularly for students. So I have this case study. This is from the Embrace report, and it's basically about this lady who was really anxious in her pregnancy because she'd experienced a previous pregnancy loss. So all the way through her pregnancy, midwives were very caring, very concerned about her. And then as soon as she had the baby, they thought, well, the baby's here now, so actually she should be okay because the baby's here and everything's fine, worked out well. But actually, her mental health spiraled after that. And they tried to get a scene and they couldn't get a scene quick enough. And actually, she took her own life. And I think what I'm trying to say is don't assume. Don't assume you know what somebody's thinking and feeling, and don't assume that people feel better because whatever the traumatic thing that was happening in their life has now gone away, because actually it still continues. And death by suicide is still really, really high amongst women. And I think with the level of birth trauma that we're seeing, this is something to take away, just to be mindful. So in terms of teaching empathy, and you can teach empathy, I always thought that empathy was something that you were born with, but actually you can teach it. So some of the things that we do within the University of Leicester is during the induction week, one of the first things we do to the students when they arrive at the university is we put them in our clinical skills bay and we put them in beds. And then we get them to wash each other's hands, and we get them to feed each other, and we get them to change the sheets under them so they know how vulnerable it feels to be a patient. And by the end of the day, what we find is instead of standing over people and saying what they're going to do, they sit down next to them and they give them eye contact. And we think that's really important. We also do a lot of interprofessional education right from day one. And we do in induction week again, a patient's journey through the NHS. Because I think if you use real people that have been through the system and people that have had certain conditions, it makes the condition real, and it makes you able to relate to it more and understand how people have to deal with that on a day-to-day basis. You're just seeing a snapshot of their life, and some people have to live with these conditions long term. One of the other things we do is we encourage our students to do case loading right from year one. So our first year students pick up 3 or recruit 3 case loading women, and they go through the service with them to all of their appointments as a professional friend. And what they do is they go and see what it's like as a woman in Leicester to go through the maternity services. And that straight away starts to give them empathy, because they have to wait in scan click for an hour because they're running late, or they can't get hold of somebody, or they see some of the fragmented services that some people have to go to and how much of a challenge that is. And as they progress throughout the years, their responsibility gets more and more. So even in first year, they're on call for their birth, but again, just to go along and hold their hand as another way of supporting them. And they really, really value it. They love caseloading. We use service users in a lot of our teaching. And again, it's getting their perspective. And the other thing we've introduced this year is we've been running antenatal classes and infant feeding classes at the university, and the students are actively participating in that as well. So they can see women's worries and fears and anxieties, and they can make a positive impact on that for them. So that is the end of my presentation. I've put some references on there should anybody want to go and look any further. And thank you very much, Sue, for having me.
That's lovely. Thank you so much, Sarah. It's interesting, isn't it? Because I think it's the kind of patient experience that really impacts, because you certainly made me think differently as you were talking. So it was really, really good. And thank you for that. I know there's a few comments coming along. I also, before I introduce Jemima, I have to say a hello to Kelty Foster, who's on night duty in New South Wales, Australia. So hello, Kelty. I don't know if you've got a question. I've got a couple of questions coming through anyway. But because we're going on to the next speaker, which is Jemima Skilling, it's my pleasure to introduce Jemima. She's a third-year student midwife studying at the University of Leicester. She's very enthusiastic about evidence-based practice and using it to improve maternity services. And she's presently completing an elective placement with the Stonygate Centre for empathic, I put an extra T in there, sorry, empathic healthcare, for which she's undertaken a project researching empathy and midwifery. So she's going to come and give some very excellent experience that she's having currently. So welcome, Jemima. Thank you so much for coming. The screen is now yours.
Thank you. Okay, yeah, so as Sue said, I'm currently doing my placement at the Stonygate Centre of Empathic Healthcare, and I've undertaken a research project there to investigate empathy and midwifery. So this is just going to be a very brief presentation of a systematic review protocol exploring the effect of empathy training for qualified and student midwives on staff and service user outcomes. Could I have the next slide, please? Thank you so much. Yeah, so as Sue said, I'm in my third year now. I'm studying midwifery with leadership at the University of Leicester. Sarah is my lecturer. And each year I've studied evidence-based practice has been my favourite module. I really enjoy it, and I'm fascinated how research can be used to improve the maternity service for both service users and staff as well. I'm on the home straight of my third year now, so I'm just completing my final placement of the year, and that is at the Empathy Centre, which is situated in Leicester Medical School, and is dedicated to improving the lives of patients through a reformation of the medical education system with empathy at the core. So as part of my elective, I've undertaken a project to research how that could be integrated into midwifery, and if it's needed as well. So to that end, I will outline the protocol now for the systematic review. This is still in construction, so I've been editing these slides a lot today because I'm doing this as I go, but it's just sort of the beginnings of it. So yeah, it's quite exciting. Could I have the next slide, please? Thank you. So in terms of the rationale and importance of doing this research, independent reports have presented the issue that a lack of empathy can and has caused avoidable harm within maternity services. So that's apparent from the Ockenden report and several others. The Francis report namely detailed that inadequate empathy perpetuated an institutional habit of ignorance regarding the service user experience, and this was a cause of the overlooking of real suffering. So that can and has caused quite a lot of harm. In addition to this, a preliminary search done by me found that inconsistent and factor-dependent levels of empathy are apparent among midwives. So these factors could be based on things like whether the midwife has had their own childbirth experience or not. And this deficiency across qualified midwives may relate to the emotional landscape of the midwifery profession rather than an intrinsic lack of empathy. Like Sarah was saying, it's sort of being something that you're just born with, but this is sort of posing that it's more of a deficiency caused by institutional effects of the maternity environment. So conversely to this, the literature shows that student midwives appear to portray high levels of empathy, in fact. So an Australian longitudinal study found that midwifery students had higher levels of empathy than actually those in nursing and emergency health courses. So that sort of alludes to the fact that midwives have quite a high intrinsic level of empathy. And this was also shown to remain quite stable throughout their studies as well. So it didn't deplete sort of toward the end of their studies, which is sort of contradictory to what is seen in medical students. Literature shows that their empathy tends to decline throughout medical school, whereas this study suggested that in terms of student midwife empathy, it was quite constant throughout the course of study. So these high levels of empathy in students may be due to the scheduled returns to university that occur throughout the course. So rather than constant working in the hospital as qualified midwives do, the return to university may be acting as a sort of buffer to those long-term effects of working in the service. So accordingly, this alludes that on account of the institutional factors, empathy might not be being maintained from pre-registration to post-registration practice in midwives. So fortunately, several systematic reviews have revealed that partaking in empathy-focused training effectively enhances clinician empathy. So like Sarah was saying, it is something that you can teach. It's sort of contrary to what I think most people would think, but I think like any other skill, you can be naturally good at it, but you can improve it. So it's not something that can't be helped, which could serve as a solution to sustaining empathy among midwifery practitioners where that deficit is apparent as well. However, none of these reviews address empathy training for midwives, so these have mostly focused on that of medical professionals. So as a result, we intend to overcome the gap by conducting a systematic review exploring the effect of empathy training for qualified and student midwives instead. Could I have the next slide, please? Thank you. So I'll just get my notes. So in speculation of what might be depleting empathy on the shop floor then, so rather than the sort of intrinsic lack of empathy that might be assumed, like we said before, Kate Greenstock in her book Flourish, A Practical and Emotional Guide to Thriving in Midwifery, described the 5 mountains of maternity work that midwives endure. So these include moral injury, compassion fatigue or empathic strain, burnout, trauma exposure and post-traumatic stress injury as well. So that might be causing the deficient empathy. Additionally, fear of prevalent litigation within the maternity service. So we know obviously that it's the highest paying out department in terms of litigation claims. So this may be sort of contributing to defensive practices such as excessive documentation, which may be harming the communication between midwives and the women that they care for, particularly during labour. Finally, a loss of job satisfaction could be harming empathy, perhaps caused by occupational hazards such as institutional bullying, which again is referred to several times in the Ockenden report as well. And they may be contributing to experiences like burnout and draining clinicians' empathy and capacity to portray it as well. So they're just some musings and some speculations that I've had in the background research. Could I have the next slide, please? Brilliant, thank you. Thanks. So in terms of empathy itself, it's often considered and described as a soft skill. And I think because of that, often gets put on the back foot in terms of research, in terms of education, and just what's seen as important, I think, in care. But its exact definition is often disputed. Mercer and Reynolds have proposed a now widely accepted definition that clinician empathy is the ability to understand a patient's situation, perspective and feelings, communicate that understanding back to them and act on it in a helpful and therapeutic way. So that's an overview. Considering the barriers to empathy that we saw on the previous slide, that the first one being deficient empathy may be caused by fear of litigation. Actually, the literature shows that deficient empathy itself increases medico-legal risk. So it's counterintuitive, really. And considering also the barrier that potentially a lack of empathy may be caused by reduced job satisfaction, actually clinicians who cultivate empathy seem to report enhanced job satisfaction and protection against burnout. So this kind of demonstrates the, I guess, almost synergistic nature between the empathy of an individual and their own well-being. So yeah, it's quite interesting, really. And then in reflection of these, I've just put the question on that slide: could empathy be an antidote for staff as well as the need of service users? Which I think it could be. Could I have the next slide, please? Okay, so in view of this information, outlined here are the basic details of the proposed systematic review that we're doing, or the protocol. So in terms of study design, we'll be looking at primary data of quantitative methodology, because we're looking at the effects. The population, we'll be targeting papers that have recruited qualified or student midwives. And this is, again, just so we can see that trend kind of going from pre-registration to post-registration practice. In terms of the intervention, we're interested in studies that have employed explicitly empathy-focused training. So this kind of goes back to the disputes and its definition. So we need to make sure that we're not confusing with similar skills such as compassion. So for each study, we'll be comparing the definition of empathy back to that one of Mercer and Reynolds that was mentioned earlier, just so that it's standardised throughout the studies. In terms of outcomes, we'll seek papers that measure staff empathic output as the primary outcome and service user outcomes as our secondary aim. So that may be things like measures of service user satisfaction, etc. And in terms of the limitations, there'll be none made on account of the duration of outcome follow-up or setting, and that's on account of the anticipated limited pool of research because it's quite a novel field, but the search will be limited by language to papers only written in English. And then in terms of the synthesis of results, the data will be pooled using a random effects model if sufficient homogeneity is identified in terms of sort of similarity of the methodology and synthesis of results. But if not, the results will be collated sort of narratively and described in terms of their themes. And as a note to end on, from an initial scoping search that I've done, it suggested that empathy training effectively improves student midwives' empathic output, which may indicate that education could serve as a partial solution to the empathic deficit that's been shown to be in maternity services. So it bodes well. Can I have the next slide, please? Thank you. So thank you for listening, and these are just the references that I used should anyone want to look into those further. But yes, thank you for having me.
Yes. Gosh, this is going to be really interesting. I mean, it's really fantastic to have that foundation from Sarah, and this work that's kind of work in progress, really exciting. So we'll have to look forward to when the findings start coming in to have some work sort of hot off the press, as it were. So thank you so much, Jemima, and thank you also to Sarah for your presentations. Now we have got some questions and comments. And the first comment is from Lindsay Ahmed. Hi, Lindsay. Lindsay was at Middlesex University, and she says, at Middlesex, we had one module which followed clients through pregnancy journey, and that required students to think about women in the round through the childbearing year. So that sort of talks to Sarah's presentation beautifully. And Lindsay then says, how can we encourage units stroke trusts to re-establish effective NHS free at point of provision parent education? Because that was something very much you were talking about, Sarah, and probably Jemima would have had an interest in that as well. Any ideas? Hot off the press.
I mean, I can't speak for the rest of the country, but I know our main practice provider, so University Hospitals of Leicester, is actually actively looking into restarting antenatal education. So I spoke to the director of midwifery a couple of months ago, and that's one of their agendas. So hopefully, fingers crossed, that will really, really help women and families.
Yeah. And especially, I guess, it wasn't so long ago, you had students working either with teachers or the midwives in the clinical area, whichever.
I mean, the staff
leading the
want to do
classes,
it.
which is,
It's
just
the
time.
deficit of midwives in the community, unfortunately.
Yeah, absolutely. Okay, well, thank you for that. I hope it's a little glimmer must be happening all the way through. We'll have a comment from Awa Hadid from UAE. Hi, Awa. And she says, can I ask if you think that women having so many choices might be a double-edged sword? It's great to have so many choices, but at the same time, it can be attributed to a sense of loss of control when the choices become confusing.
Yeah, I completely agree with that. And that's why I said it's really difficult to navigate the maternity services, because everybody now carries a computer in their hand. And, sometimes the internet is your worst, the worst thing that you can do. But I think it's more preparation, I think, for how pregnancy and how labour and birth might unfold. You don't have to go into every single detail. You need to tailor it to that family. And I think that's the important bit, is making sure that care is really individualised. And actually, what do they want to know? Because some people really don't want to know.
And of course, sometimes they've got a lot from social media or from the TV, which I think you highlighted brilliantly, Sarah, where it's a picture of pregnancy and labour that may not bear very much relationship to that woman's experience. So that's I'm thinking. Okay, another comment, and this is from Jill Phillips, who the shoes lady. Hi, Jill. And she says she agreed, acts of compassion can be tiny but make such a difference. And I think that was about you talking about touch, Sarah, and kind of making sure the person knows you're listening. Loving this talk and the practical examples you're given, Sarah. So thank you. That's lovely, Jill. And another comment from Jill. Love the induction week you described, Sarah. Students in beds experiencing how it feels to care, be cared for. I was so proud of my friend, and this is Flo the obstetrician, Florence Wilcock, who we've had on the hour. When as an obstetrician, she started her TEDx talk in the lithotomy position. If not, people haven't seen that, by the way, do go on and look up the lithotomy position with Florence, and it is really fantastic because she was just mesmerizing. It was such a fantastic thing to watch. So thank you, Jill, for reminding us about that. Then we have Juliet Samuel in Essex. Hi, Juliet. A regular person is Juliet. And she says, Sarah, is there a place for including emotional intelligence training as to improve the midwife's empathic skills?
I think definitely. I think we intertwine it through all of our modules. I mean, I know Jemima was saying that, in medicine, the empathy declines throughout the training, the evidence is there. And I think that's because in medicine, it's almost seen as an additional thing that's not mandatory. And when you've got that much to learn and that much to do, you don't want to be taking on anything additional. So I think it almost needs to be mandatory, filtered through the entire curriculum. And I also think, again, what Joanna was saying, people have an ideal view of what maternity services is, and then they see the realistic view of maternity services. And it's about when the students, before they go on placement, prepare them for what they might see. And actually, when they come back, have a very good debrief session with them. Because what we don't want is for them to be taking anything that they're worried about or they saw that they weren't very happy with through the rest of their training. It's important to have a talk about that, kind of disassociate themselves from it, if you like, and find out how to move forward. And I think that's something that we do with our students quite well. I mean, Jemima will tell you whether or not we do, but I'd like to think that we do that quite well with our students. And we get the trust involved as well. So the trust actually come in now to our debrief sessions, and they see what our student midwives are experiencing, which has been evaluated very well.
Fab. Well, I was actually interested, Jemima, when you were talking about one of the research projects that you was the foundation of some of the work you're doing, when you were almost talking like the students being able to hold on to their empathy skills at a quite high level, and it was almost like that you were talking about the buffer of coming out of the clinical area into, if you like to use that term, as a kind of I was thinking it's like having a break from the kind of pressure of clinical. I don't know if you've got some thoughts about that, because from what Sarah was saying, that kind of had a real good tune for me.
Yeah, I think just from personal experience, because this was sort of more based on my my own sort of personal anecdotal experience. But even when you're on placement, there's that kind of feeling, I've got 5 weeks left, I've got 4 weeks left, I've got 3 weeks left. And you may be enjoying it, but then when there are times when it's difficult, there's always that reassurance in the back of your mind. Whereas I can only imagine that when we're not going back into uni and it's just the
day
job
after day. Yeah.
There's no end, do you know what I mean? There's no sort of end in sight. So I think that probably sort of accumulates the sort of barriers to empathy, I guess, when that support just isn't there and it doesn't seem to be getting better. Yeah.
And it's especially difficult when clinicians are so busy these days and can't. It must feel like you're on a little hamster wheel, whereas at least the students can hop off their hamster wheel onto another hamster wheel and actually have a chance to reflect and think about different experiences they're having. No, that was really fab. Okay, and we've got Awa again. I was always asked good questions. Did you look at as if empathy was different in midwives when looking after women from different backgrounds, culturally and linguistically diverse? Now, I'm not sure if that's directed to Sarah or Jemima, but I mean, that's certainly an issue whether some midwives might have different approach. You know, empathy might be seen as a bit too soft in some groups of people. I don't know. Don't know if that's something you've looked at, Sarah.
I think it's about cultural competency. I think it's really important that, especially our students are exposed to, because people view childbirth very differently across different cultures, and even the way they, I don't know, how they want to labour and how they want to give birth, and some of the choices are very different. And I think traditionally we've just been taught, you know, the British way, and you know, this is like a standardized thing for everybody. And I think that can be quite dangerous, because again, we're putting people into boxes where they don't belong, and it's about that individualized care. And it's okay to ask somebody, what would they want you to do? Tell me about how you perceive pregnancy and birth, and let me help you navigate in your own way.
It's getting the woman to actually open up and say what is acceptable, I guess, or what she might think is acceptable. It's quite tricky, isn't it? I've got another comment from Jill Phillips. Thank you, Jill, who's also sent a lovely picture of Whose Shoes, which is the project that Jill's very much been involved with, this for some time, which is getting people very much to walk in other people's shoes, feel what it feels like. And she says empathy, only a soft skill. Brilliant to hear the evidence here, Jemima. Good. This is similar to the argument that patient experience is the fluffy side of patient safety, but being listened to and feeling safe leads to people feeling be able to speak out. It's not an either or. Empathy, compassion, kindness, all a bit different, all super important. Beautifully put, Jill. I can't put it better. None of us can put it better. Thank you so much. That's lovely. And she's done a lovely picture of the shoes online. So thank you for that. And another comment, again, Jill, I think this talk is spot on. Thank you. When the recording is published, I'll aim to put it on our maternity experience, Whose Shoes Padlet. Fabulous. We're famous, fantastic. And then we have Lily Sunseeker. The culture within a unit is paramount to the levels of empathy showed and is also referenced by the Say No to Bullying Midwifery book. Well, I think you mentioned about the bullying, Jemima, and that certainly is an issue, I think, for some midwives, maybe not feeling as though anyone's empathic to them, and therefore it becomes a problem for others. Now we've
Can I
got,
just say, Sue,
yes,
that when I used to work on the wards, I always used to offer, when the doctors came down for ward round, the first thing I did was offer them a cup of tea. And I always say to the students, you know, if you're working with somebody and they are having a particular bad day, or, you know, they're not in a good place, just again offering them a cup of tea. Have you had something to eat today? You know, can I do anything for you? It's really important to look after each other and look after your colleagues as well as the women, because if we care about each other, we'll provide more care to the people that we're looking after. So I think it's equally as important to show that empathy to your colleagues, and that will then hopefully foster a better culture of a better climate.
That's lovely. Jemima wanted to say something, I think, at that point. Did you? You looked as though you're going to look.
I'm just interested. No,
it's fabulous.
I think I was just going to say, like, I think even in the literature as well, I think harm is done not just when midwives aren't empathetic to the families they care for, but when people aren't empathetic to midwives, because it feeds into their own empathy. It's like you're pouring from an empty cup. So it starts way back with how staff are treated. It's not just the intrinsic lack of empathy. I think it's important to note. Yeah.
That's beautiful. This is wonderful, wonderful. I don't want this end. This hour is coming to an end. I don't want it to end. And we've got another from Lily Sunseeker. And she says, regarding antenatal education, this has been tendered out to private companies in Leicestershire for several years. I'm sure this is the same across the country. So it'd be great to bring it back to in-house midwives. I absolutely agree. As a I used to love doing parent craft, and I know women love to have midwives talking parent craft with them, the people that they're going to see. So I absolutely agree, Lily. And finally, I've got Jenny. It has to be final. So Jenny Hall, your final word says, great work, and humanized care so important. A study from years ago of independent midwives indicated they felt empathy in their bodies, experiencing physical responses to the women in labour. Do you think there should be more discussion on the intensity of the midwife experiences? I think this might be one for Jemima, actually, with all the work she's doing.
In terms of what midwives experience in the job, you mean?
Yeah.
I think so, because I think, sort of like what I was saying about what Kate Greenstock wrote, sort of those 5 mountains of midwifery. I think vicarious trauma is a big thing. There you go.
Yeah, it's here.
I can see mine. I just can't read it.
Recommend it.
I think, the vicarious trauma is a huge thing. You're there for every moment as a midwife. You're not someone who's popping in and out. You're not a doctor popping in and out the room. You see the whole. You go through it with them, sort of on a bird's eye level. And I think it's sort of naive to assume that you don't take that with you. So absolutely.
Fabulous. Yeah. Well, I think this has been a fabulous time, and thank you so much for Jemima for sharing the work that you're doing, and for Sarah for sharing the work you're doing, and just giving us all wonderful things to think about. That cup of tea for the doctor that looks exhausted, hasn't, because you hear about people saying nobody cared, I got bullied, you know, I hadn't had a rest all day, that all that sort of thing. To have that care, I think if we can all care for each other the way we should, it has to get better and better for the whole service. So thank you so much for really bringing that alive for us today. Now, I'm going to say this is always the fastest hour in the week, and it's been really, really quick this week. So a huge thank you to Sarah and Jemima for joining us this evening. Also to Angelo, who's been doing some of the slide moving, and also, more importantly, in some ways, he's going to make sure everything's packaged nicely. So that those of you who like a 6 o'clock in the morning podcast on Friday will have one, because that's him making sure that works. And of course, it'll all be available next week on all the other platforms that you can access with those. And I also say thank you to Deborah in the background, also Paul, who's feeding the questions through to me. I should have mentioned that I have to look over there to get the questions. Apologies for keeping on looking away. And also the resources are there. We've got a whole big reading list. You don't have to read everything, but some of the things, especially that Jemima and Sarah have put down, are really useful references. And some of them are lighter than others, I would say, but they're all good pieces of work that you'll find interesting and useful in your lives. Now, I'll see you next week for Maternity Midwifery. And we're going to look at women's voices in the classroom. So it's another sort of classroom-y thing, but not quite. We have Claire Nutt and Teresa Shalowski next week with us. Don't forget to book for the Northern Festival on the 18th of June. There's only a couple of weeks away. And then if you fancy a trip down to Bath, we're going to be doing the Southwestern Festival on the 17th of September. And you might want to book for that as well. Remember, and I should have said right at the beginning, everything's recorded with the Maternity Midwifery Forum. So if you miss anything, as long as you've registered it for it, you can always access it afterwards. So in the meantime, I'll say another huge thank you to our lovely guests, and a thank you to a fantastic audience who've given us so many fantastic comments, questions, and really engaged with us beautifully. And thank you for coming along this evening. See you next week. Take care. We'll see you then.